stable, you can actually gradually wean it down. Or we'll talk about how we can wean medications down or add on therapy and so on. But again, the foundation has to be lifestyle changes. There is of course the medical and the surgical therapies. We'll just touch upon it briefly. Now, anyone who has acid peptic related disease, it is important to check for H. pylori. Now, I think with GERD, there is actually no direct relation to. However, when someone comes with dyspepsia or acidity, they usually have some gastritis symptoms as well. Now, if you don't check it and the third doctor checks it, I think they're going to be very unhappy that the first two doctors didn't do a check for H. pylori. Now, H. pylori, as you probably all know, is also a precancerous bacteria. So it's important to make that diagnosis and to treat it. So a question that patients will often ask you, where did I get it? How did I get it? Unfortunately, it's a very common commensal and usually acquired in the developing countries very early on. You can see that by the age they're 50, 80% of patients usually have H. pylori. But in the European countries and across the Atlantic, it's usually much less, about 50% in patients who are between the ages of 18 to 30. So it's a much smaller number. So H. pylori can cause gastric ulcer, duodenal ulcer, as you can see. Very important to be aware of these conditions. Now, we talked about antibiotics briefly. The reason, with antibiotics is there's a lot of resistance. An important a step in making the diagnosis is not to use H. pylori serology. In all my talks, I reiterate the importance of not using H. pylori serology, because serology will only tell you of previous exposure. It's urea breath test or H. pylori stool antigen that tells you whether the infection is active H. pylori, and only treat based on active H. pylori disease. Another important message is, if you test for H. pylori, please make sure you treat it, because medico-legally you are liable to treat that patient if you've tested it. Because if you don't treat it, and let's say 8 to 10 years down the line, if that patient was to develop gastric cancer, they can come back and sue you. So medico-legally, you are culpable. So just make sure if you test it, you make sure you treat it. Another important message, once you've treated it, always 4 weeks later, make sure you test it again, because just because you've given the treatment is not guarantee that the bacteria is gone. We've had patients who have failed with the conventional regime, with the Pylera, with the Talicia, and so on. So it's important to make sure that you do test, treat, and retest. So remember this algorithm, which is test, treat, and then retest. So what's new and what's not? So this conventional regime of metronidazole, amoxicillin, PPI, the clarithromycin, amoxicillin, PPI, the Tavanic, amoxicillin, PPI is no longer recommended. So it may come as a shock to you, because there are still patients who are being given this regime. So the American College guidelines, the British guidelines, and all the guidelines have taken these medications off the list. So please do not use these anymore, because the resistance is high. And here in the Middle East, metronidazole resistance is about 70 to 80%. Clarithromycin resistance is anything between 50 to 60%. So no self-respecting gastroenterologist will use these regimes anymore. In fact, it's been taken off the guidelines. So we can come to the H. pylori eradication current options that are there, and we can perhaps discuss that in the Q&A sessions. So we'll come back to the reasons why people develop gastroesophageal reflux. So the first thing is the esophagus has a mucosal clearance mechanism. The important is the lower esophageal sphincter, gastric emptying, and the mucosal integrity. So anytime there is a break in this barrier, for example, lax esophageal sphincter, hiatus hernia, can all cause gastroesophageal reflux. Here you can see that the stomach has migrated up into the chest above the diaphragm, and the acid bearing area now is in the chest. And that's why you can expect this patient to be having reflux symptoms. At some point, we all go through, if you've eaten some spicy, fatty, oily food, citrus fruits, chocolates, caffeine, especially caffeine on an empty stomach, all these will have reflux symptoms. So don't hesitate to refer patients for endoscopy when anyone has symptoms for more than 3 months. Please avoid repeated PPI prescriptions. And we'll come back to that in a minute. But anyone who has symptoms for more than 3 months need to be referred for an endoscopy, hiatus hernia, to look for lower esophageal sphincter tone, to look for Barrett's esophagus, to look for the grade of esophagitis, to check for H. pylori on the biopsy, to look at the gastric mucosal integrity. Then we also do the duodenal biopsy. So, it's a 5-minute procedure done under propofol sedation. It's not even general anesthesia, and probably one of the safest procedures, diagnostic procedures that is there to have. So why would you want to defer this until the patient develops complications? So please, anyone who has symptoms for more than 3 months should be referred, or at least try and wean them off. If they're able to wean it off and they remain asymptomatic, understandably, they don't need anything doing. But if they continue to have symptoms, and you feel you need to give them the PPI, anyone who is dependent on the PPI needs to be investigated further. Another thing to remember is if there are any medications that can reduce the lower esophageal sphincter tone, it's important to be aware of this, especially the calcium channel blockers, tricyclic antidepressants. And if patients are repeatedly having symptoms and you're having to give repeated courses of PPI, try and see if there is any trigger foods. Smoking, we talked about it, and we mentioned briefly the chocolates and caffeine as well. So, so here on the left, as you can see, the lower esophageal sphincter normally is very tight and closed and allows, as the food goes down, it opens up. But when there is no active chewing or food going down, the lower esophageal sphincter remains closed. But here you can see a very lax lower esophageal sphincter. And as a result, the gastric acid is coming up into the chest. And the result is, as you can see on the right, it's a grade 3 to 4 esophagitis. This can result in esophageal stricture requiring dilatation, and dilatation carries a risk of bleeding or perforation. Another complication of chronic reflux, as we mentioned, is Barrett's esophagus, where the stomach lining moves up into the lower esophagus. And that is a precancerous condition as well, causing adenocarcinoma of the esophagus. I get a lot of referrals from my fellow colleagues, from the chest physicians with dry, non-responding cough, asthma triggered by GERD, hoarseness in the voice. ENT doctors refer, dentists refer, cardiologists with non-specific chest pain, which they've not been able to identify a cause, but the patient continues to have symptoms. Now, these patients are, conventionally treated with PPI, and most of their symptoms come under control. So briefly, I just mentioned about endoscopy. It's a diagnostic test, very simple, very straightforward, done under sedation with no discomfort to the patient. Procedure takes 5 to 10 minutes max, and the patient only need to be in the hospital for about an hour or so and discharged obviously on the same day. So when it comes to treatment, I think the first and foremost is to teach and educate your patients. As with any medical, I'm a great advocate for patient education. I think, with the first consultation, take an extra 5 minutes, educate your patients, tell them why they have a particular condition, and then reach for the medication. 50% is done by the education with the patient's involvement, and the other 50% is by the medications. So we talked about PPIs and its safety. They are generally very safe. However, no medicine is good for you unless absolutely necessary. So previously, we used to think our PPIs are absolutely fine. It's okay to continue forever and ever. But as we use medications, we realize that there are obviously side effects from it, and one of the thing is Clostridium difficile. Now, this is pretty straightforward. You're increasing the stomach pH. So when you're allowing, normally the acidic environment keeps the bacteria in check. So when you increase the pH and make it alkaline, surely the bacteria are going to start dancing and then cause problem. So there's an increased risk of C. difficile in patients on long-term PPI. PPI and dementia, PPI and pneumonia, especially in intensive care patients. PPI reduces the effectiveness of the antiplatelet agents, renal impairment, micronutrient deficiency, and calcium absorption. So, hence, the osteoporosis and osteopenia are all implicated. So, these are all the studies on C. difficile. We won't go into too details, but there are others. Even in the World Journal of Gastroenterology has mentioned PPI therapy and the risk of C. difficile and dementia as well. So if someone, especially the elderly patients, unless there's a very good reason to, don't put them on PPI. And drug interaction, and especially I think you will all have patients who are on antiplatelet therapy, especially clopidogrel. Remember, there are PPIs that interact, especially because of the cytochrome P450. So it's important to use a PPI that does not interact with the clopidogrel, and that's pantoprazole, Dexilant, and lansoprazole. These are the PPIs that you should be using if your patient is on clopidogrel. If they are on another PPI, you ought to switch them because the clopidogrel efficacy comes down. So I hope that's another important message to sort of take on. Renal impairment is there, and you probably all heard this headline where ranitidine was taken off the market, the FDA advised. And this happened, I think, about 6 years ago. But that does not mean it's a class effect. It was only the ranitidine that was the problem, because H2 receptors are actually a very useful medicine for us to use. It is safer and it is an alternative to the PPIs. So this is where we should either step down or add on therapy. So it is safe with very minimal side effects, and it has no effect on P450. It does no effect on the liver enzymes, and it's a category B, which basically means it's very safe. So the American College Guidelines, American Gastroenterology, and the NICE in England all advocated the same. So basically what I do, what we gastroenterologists do, is we'll always, here in the UAE, we will always start them on a PPI. Once their symptoms are coming under control, what I would do is I'd say, okay, now that your symptoms are under control, try taking it alternate days and see if you're able to do that for about a couple of weeks. And if you're still okay, take it every 3 days, as in 2 days off, 1 day on, 2 days off, 1 day on. And if you're able to step down, gradually get them off it. But then if their symptoms sort of come back, what I would do then is I would alternate with a PPI and famotidine. So 1 day PPI, 1 day famotidine, ablazer. So what then that helps me is to get the patient off the PPI slowly. And the patient also is aware that he is on a medicine to keep his symptoms under control. So the idea is to keep the lowest effective dose and for the shortest duration, and see them in the clinic, establish a rapport with the patient, continue with the lifestyle changes. You probably need to see these patients for about 6 to 8 weeks, maybe up to 3 months. And then if you're able to get them off the medicine, that's the best scenario. But if not, use the lowest or the mildest medication that's required. So as I mentioned earlier, famotidine has no drug interactions, no cytochrome P450 inhibition, and it is safe, and none of the side effects, long-term side effects that we would experience with the PPIs. Going back to the same thing, lifestyle modification, lose weight, stop smoking, and reduce caffeine. Anti-reflux surgery, we use it, very rarely, especially now that we have a lot of other medical options. There's also there's something called TIF, which is transoral incisionless fundoplication, which I do, which is an endoscopically for patients where they have a lax lower esophageal sphincter. We can actually tighten the lower esophageal sphincter by endoscopy itself. So I think the take-home message really is PPIs are very good, but not to be used long term. the side effects of long-term PPI usage it's not as benign or harmless as we initially thought. So always try and get them off the PPI if you can. So wean them down, which means if you're unable to get them off the PPI, use the famotidine and see if that will keep their symptoms under control. In fact, I've had patients where they've said, "Doctor, this medicine is better than the PPI," because they've been on the PPI for a long time. So what happens is your body gets used to it, and then they're no longer effective. I've seen patients change from one PPI to the second to the third and the fourth PPI, and the patient comes and says, "Doctor, I've been on 4 PPI, 5 PPIs, and it's still not working." To be honest, if 2 or 3 PPIs don't work, either your diagnosis is wrong or you've not managed it appropriately. So use the famotidine in addition to the PPI, because remember, one is a proton pump inhibitor and the other one is an H2 receptor blocker. The two together will work effectively. So for those resistant patients, you have to combine them. So that's like an add-on therapy or like a synergistic effect. But if the patients are responding to the PPI, try and gradually reduce it, switch to famotidine or an H2 receptor blocker, and then gradually wean it down. If you're able to come off the famotidine as well, of course, ideal. No medicine needs to be taken long term unless absolutely necessary. But if you want maintenance therapy, that is the best way to go about it. If the patient has reflux, as in, they say, "I don't have any acidity or stomach pain, but I get reflux symptoms and heartburn," so use the H2 receptor with one of those, these medical devices. We used to have what we call ESOX. I don't know if you remember, but then there is something now called Isolif, which is basically what it does is it paints the lining of the stomach. Therefore, when the acid comes up, it doesn't allow contact with the esophagus. Use the 20 or the 40 milligram. Personally, I like the 40 milligrams. I use the 40 twice a day, again, with a view to gradually stepping down, with a view to coming off it. You're okay to use 40 milligram twice a day to begin with. Then if they have only symptoms at night or in the early morning, I just use the once at night just to keep the symptoms under control. So again, reduce the PPI, use H. pylori, test, retest, test, treat, and retest, and use the H2 receptor blockers in order to either as an add-on therapy or to step down. And the most important, please educate your patients. I'm sure we all do at some point, but then sometimes what happens is our clinic is so busy and inundated with patients and other admin activities. We just opt to just give the medication. I mean, the follow-up patients are fine, but I think the new patients that we normally give the 20 minutes or so, the extra 5 minutes goes a long way to in order to educate these patients, and it helps with the management. Patients are, if the patients also want to be involved in their management. So if they don't know why they've got a certain condition, of course they're not going to take the medication. It's a bit like the PPIs are to be taken on an empty stomach. But if you don't tell them that, it's not going to be effective. They have to take it either half an hour before food or 2 hours after food. And the barrier devices, this Medireflux, the ESOX or the Isolief, they have to be taken after food. Now, if they take it with food or as soon as they take it and they drink it down, it's not going to be effective. All these are part of our education strategies that we should be using. So I think with that, I will conclude my talk and leave time for questions. I can stop sharing my screen and then I'll hand over the floor back to Ahmed and Sandhya.
Yeah. Thank you so much, Dr. Shamsher.
If you have questions, you can come on the there's a chat box as well, or if you want to, you can have question and answers. If you're happy to come on the mic, please unmute yourself and ask away. Absolutely, be delighted to address any issues. Or if you have any learning, we're all here to learn. As I said, if you have any comments or you find from your practice, we will be more than happy to learn from your experiences as well. Thank you, guys.
Yeah. Doctor, they can only put question answers on the question answer session. They'll not be able to doctors, if you have any questions, kindly do put on the question and answer section. So I can
Right. Okay. So I'll go through. I think there is already one question here that I see. I'd like to know regarding the new regimen for H. pylori treatment. Right. Okay. So that's I deliberately left it out for the quick Q&A session. So basically, the current regimes, there are three H. pylori regimes that are approved by the American College of Gastroenterology. Um, so the first is the recommended is Pylera or Talicia. So Pylera is, as you know, it is 3 tablets 4 times a day for 10 days. So that's the first one. That's the bismuth quadruple. Or you can use Talicia, which is the rifabutin, amoxicillin, and the PPI. That is 4 tablets 3 times a day. So this is the advantage of the Talicia is that it's 3 times a day rather than 4 times a day. The third option, which is now, and you're probably going to see this a little more in the coming months, is the new, you probably heard of the PCAB, which is the potassium competitive acid blocker. That is vonoprazan. I don't know if you've heard of it. It's coming, it's here. We've got, I think, Julfar is coming and CDI is coming up with this as well. So vonoprazan with amoxicillin. So there is vonoprazan with amoxicillin. This is called the Voquenza, which is the dual therapy, or vonoprazan triple therapy, which is vonoprazan, amoxicillin, and clarithromycin. That's the triple regime. Again, with the early results are pretty good. It's 85% plus eradication regime. But so these are the three, as I mentioned: amoxicillin, erythromycin, meloxicillin regimes, augmentin are all out. So please don't use them anymore. So the second question is, why do we give combination of PPI and H2 receptor blockers? So this is because it's synergistic. So PPI will reduce the PPI. It is a much stronger acid suppression. H2 receptors is not as effective as a PPI in terms of acid suppression, but because they work at two different mechanisms, the effect can be additive. So what we call synergistic, and therefore reduce the reduce the or increase the stomach pH significantly as well. So when you combine the two, again, I'm not recommending it for long term, but for short term, it's definitely useful. Does fermented foods at night aggravate GERD? There's no evidence to suggest that, but having said that, every patient is different. I've had patients who say, every time I eat a banana, I get quite severe reflux. Patients don't always follow the books. Patients don't read the books. So just because it is not suiting one person does not mean that there's no one size that fits all. So if for that particular patient it doesn't agree, I think you say any food that doesn't agree with you, keep away from it. How long can you use as maintenance, both PPI and S2 receptor dose? So generally what I tend to do is my figure is anything between 6 to 8 weeks. So I normally give the PPI for about 4 weeks, and I say, come back and see me. Right, how have you been? And we've tested for H. pylori. We've addressed all the lifestyle. And when they come back, I make sure they address all the lifestyle questionnaires that we talked about, saying, is there anything that you can do better in terms of citrus fruits? Are you avoiding them? Are you avoiding coffee? Have you stopped smoking? Have you lost weight? Do you make sure you eat small meals, little and often rather than big meals? And make sure you don't lie down completely flat. Use, elevate the head end of the bed. Chew your food well. All these, don't eat very fast. All these things make a big difference. So maintenance. So after 4 weeks, I try and tell them, okay, now take it every alternate day for 2 weeks, and then every third day for 2 weeks, and then see if you can come off it, and come and see me at the end of 4 weeks. So that's by the time it's been 2 months, right? At the end of 2 months, again, I address all those lifestyle questionnaires and just make sure that they're. Then, if they're still say they're not able to come off, the PPI or the medication, then I would say, let's try the H2 receptor either as an additive or to a step down to see if we can, and then gradually see them after about 4 weeks. So this is what I said earlier. I usually follow them up for about 3 months or so. Now, if somebody is dependent on the PPI or unable to come off it, that's the indication. That's the time when they would need an endoscopy to look for Barrett's, lower esophageal sphincter tone, hiatus hernia, gastric atrophy, H. pylori, all those things we need to check. Does the blood clot test for H. pylori test well relevant? I presume you're asking about the serology, Dr. Siad. I think if that's what you're mentioning, and the answer is no. We don't do that. Blood clot test for H. pylori, no. So only the urea breath test. But for the urea breath test, remember you have to stop the PPI for about 2 to 4 weeks, minimum 2 weeks, ideally 4 weeks. Otherwise, you'll get a false negative result. If after one course of H. pylori went to check, so yes, so you have to check for H. pylori anything after 4 weeks. If you do it any earlier or sooner, it can be a false positive, because even after you stop the H. pylori treatment, it still is affecting. So give them 4 weeks after treatment before you check H. pylori. So if you've done a urea breath test before, you do the same urea breath test after. If you've done a H. pylori stool antigen, you can always do a urea breath test or an H. pylori stool antigen 4 weeks after you complete. And if again positive, can we give other options? Of course, in fact, it's recommended that whatever. So let's say if you've given Pylera, and after 4 weeks, when you've tested them, if they're still positive, you have to use the alternate regime. Giving the same regime is not recommended. You have to move to a different one. As I said, there is Pylera, there is Talicia, then there is the vonoprazan with the amoxicillin dual therapy, or vonoprazan with clarithromycin and amoxicillin triple therapy. If metronidazole resistance is more than 70%, what should be the alternate? And my second question is, if a patient is can we add famotidine? Right, okay. So metronidazole resistance metronidazole is out of the question, not to be used at all. So Pylera, Talicia, and Voquenza, or the vonoprazan regime, these are the three antibiotic H. pylori regimes that you should be using from now on. If a patient is on clopidogrel with pantol, can we add famotidine? And the answer is yes. The question is, do they need it? As in, why would you want to add famotidine? If their symptoms are under control, there's no need to add famotidine. But pantoprazole, as I told you, is safe with clopidogrel because that has no cytochrome P450 interaction. But if their reflux is the reason that you want to escalate the therapy, then yes, you can always add famotidine. Again, do it for a shorter period with a view to trying to gradually reduce it. What's the maximum duration we can use H2 blocker? That's a good question. I mean, I think you can use it for definitely longer than a PPI, because with the famotidine being much safer, it would be okay. But the bigger question is, does the patient have symptoms? And if the patient, for as long as the patient has symptoms, it is okay to put them on the medicine, even PPI. I'm not against PPI, don't get me wrong. I'm not against the fact that they are on PPI, but if you can step down to an H2 receptor blocker, that is a better option than to keep them on a high dose PPI. So for as long as the patient has symptoms, it is okay to put them either on H2 receptor blocker. I do have patients who are on long-term PPI as well. I'm not saying I'm anti-PPI, but these are patients who have tried the H2 receptor or add-on, but are unable to be maintained. Their symptoms don't come under control on H2 receptor blocker. Then they need to be on long-term PPI. But if you can, and if you have the option to reduce or tailor it down, always reduce to a much safer option, which is the H2 receptor blocker. Can famotidine only use for long-term good? Yes, if they have symptoms, absolutely. As long as their symptoms are under control, so you have to be guided by the patient's clinical symptoms. So give them the medicine, see them after 1 month. So I'm very against, sorry to say, the 3-month prescriptions of PPI, because anything can happen in those 3 months. I mean, patients, you're not giving the patient enough time to try and come off. you don't know whether they actually genuinely needed it for 3 months, and you will have reduced their stomach pH for unnecessarily, and they will have developed SIBO, which is, small intestinal bacterial overgrowth, which then means that they need to be on another antibiotic, which is rifaximin, that we tend to use. Is pharmaceutical cost effective then? Oh, 100%. I mean, for sure, definitely. I mean, see, cost is a secondary factor, but more important is the patient's health benefits. So yes, famotidine on both levels is cost effective, but also much more. I think in terms of, if you do the risk stratification, the famotidine is definitely much safer for the patients in the long term, if a patient was to need it. Please explain the position a patient should sleep if he has GERD. Does sleeping on left or right help in the nocturnal reflex? Sleeping on the left or right is individual preference, but the position of the patient. So it's not using two pillows. I mean, I think a lot of people say, Doctor, I use three pillows to sleep. When you use three pillows, all you're doing is you're just flexing the neck, and that's not really what is recommended. What you have to do is the old the description was, you have to keep a brick or two under the head end of the bed. So the bed needs to be at a not quite 45 degrees, perhaps at a 30-degree or a 20-degree angle. So sleeping, because of the gravity itself. So pillow, if you use, all you're doing is flexing just the neck part of it, which doesn't help, because all the problem is happening at the geo junction, remember. And when you're using three pillows, so it's actually elevating the head end of the bed rather than the head end of the mattress. So that's important, Dr. Rajaz. Some patients are reluctant to stop PPI and self-medicate for years together. How to educate them? So I think I tell my patients, I think if you take these medications long term, you could be doing yourself damage. I understand, and I know, and I have patients similarly as well, who take these medications long term, but unnecessarily. It is a psychological, it is more for their brain rather than for their stomach, to be very honest. So you have to tell them that this is going to do you harm, plus the other medications that you're taking can be rendered ineffective. There are the other complications with these long-term medication. So tell them, don't abruptly stop it, because they are going to feel their symptoms. So the best way is to wean them down. As I mentioned earlier, you take it alternate days, and then you tell them to take it every third day with a view to gradually coming off it. And then in between, you can always introduce the H2 receptor blockers. Dr. Adhikary, which one is recommended in terms of more specific for diagnosis, stool H. pylori or serum? Serum is out. Serum is only testing, will tell you about previous exposure. You should not be treating anyone based on H. pylori serology. The serum is no longer recommended. Not no longer, it should be just out of the question. We shouldn't be doing serum H. pylori at all. And if you treated someone based on their serum, I think you could be questioned, because that's just indicative of previous exposure. And I've seen patients who were treated with the H. pylori serology and then followed up with H. pylori serology, and surely it's going to be positive, and then treated again and treated again, and then antibiotic resistance and so on. So you can see a cascade of events that will lead to the problems and antibiotic abuse. And when this patient specifically needs an antibiotic, either for septicemia or UTI or lower respiratory tract infection, it's no longer going to be effective. So that's why I said earlier, the PPI and the antibiotics are perhaps the most abused medicine. Use it if absolutely necessary. Can antacid be a good option for GERD? Can we wean off PPI with antacid? Yes, of course. I mean, you can use any of the tools to try and get them off. The idea is to get their symptoms under control. Once they're under control, gradually try and wean them down. Once you manage to wean it down, try and see if you can actually push it even further by stopping it even. But you will only be able to do it provided you combine all of these with lifestyle changes. So remember my second slide. teach, educate the patient, and with that only you will be able to do this. Any reasons why GERD is increasingly seen in teenagers? Oh, that's very simple. It is, Dr. Milan, because of obesity is going up, lifestyle. It's because of increase in smoking. I mean, the smoking numbers are going up, obesity and the processed foods. And H. pylori is also becoming more and more common, not necessarily for GERD, but for gastritis. We are seeing, and another thing I forgot to mention, if you have a patient who has H. pylori positive, make sure you ask for their partner also to be checked. At least 60 to 70% of their partners tend to be H. pylori positive. They will ask you, do I need to check my child as well? And the answer is no, don't. Don't. That's like opening a can of worms. And you don't want to give a child antibiotics unless it's absolutely necessary, because they have their normal mucosal inherent immunity. So that will be taken care of. But adults, because they're at increased risk of cancer as well, so their immediate partners, if it's a husband, check their wife. If there's a wife who's positive, check their husband. And so just to ask them to do a stool test or an H. pylori urea breath test. And if they're positive, treat them as well. So yes, it is increasing in teenagers. You're absolutely right. So next question, what's the maximum duration we can use? We talked about that.
I think
Is
you've covered all the questions, doctor.
Sorry?
I think you've covered all the questions.
Right.
That was the last
Maybe not.
question.
That was the last one. No, well,
Yeah.
there's one more. And it is
Oh,
okay. We
recently.
see a lot of pediatric cases with abdominal discomfort and symptoms. Is PPI good for children? Mostly toddlers. No, I think the safety. I mean, Sandhya can tell us what age group H2 receptors are indicated. For toddlers, no, we tend not to use the PPI. I mean, the omeprazole 10 milligrams is licensed for children, but 10 milligrams we use. But again, um, in children, we should generally try and avoid any medications, especially antibiotics, because their gut flora is just growing. Remember, gut bacteria is your second brain. So very important to maintain the homeostasis and not to destroy the gut bacteria. So if there is one medicine you want to avoid in children, in infants, is antibiotics. So the second one is probably the PPI, because allow the bad bacteria to be in control, and allow the good bacteria to grow, so that they have a better adult gut hormone profile. What can we do with children with abdominal discomfort? Now, that's a very general question. I think, again, it depends on what the abdominal discomfort. Most of the children, it tends to be irritable bowel syndrome, but then celiac needs to be excluded. Not every child needs their H. pylori to be checked, because it would then mean antibiotics, obviously. But ultrasound, routine blood tests, it depends on the underlying symptoms, to be honest. I mean, abdominal discomfort is a whole day of discussion altogether. But celiac, unless the eyes do not see what the mind does not know, as they say. So it's important to sort of check for celiac disease and to pick it up early before the complications ensue. I think we're coming to, that was probably the last question, I think. Anything else? Or any comments if you have? Thank you, Dr. Adhikari. Thank you, guys. Sandhya, I think that's 10:01.
Yeah, no, and it's too long as such,
On
doctor.
the money. Do you need to,
Doctor, one more question. One more question. I have seen many doctors who are prescribing, PPA along with an NSAIDs and an antibiotics or even with steroids.
yeah,
Even I could
yeah,
see many pharmacists also dispensing PPA
yeah,
along with an NSAIDs. So,
yeah.
is it the right treatment or can we,
No, I mean, the guidelines do not recommend, it is not advisable. However, if a patient has previously had a peptic ulcer or a GI bleed, if there is evidence of it, then yes. But every patient who goes on to steroids or aspirin or NSAIDs do not need to be given a PPI,
okay.
because there is no evidence that it will actually, in fact, you could be doing them harm. So why would you want to give somebody a medicine when it's not really indicated? But if you feel they're at high risk and they're going to be on long-term NSAIDs, and like an elderly patient, and they're going to be on a high dose diclofenac or Voltaren, and maybe for 2 or 3 months, then I think it's very reasonable. But you could also use the estrogen receptor blocker as well, just as a protective. But if they've had peptic ulcer previously or a GI bleed, then yes. But routinely, conventionally, not advisable, not
Yeah.
required.
Because I've seen
Is
even for
famotidine, what
one,
age group is famotidine licensed for? From what
three
age?
months, about three
From
months.
3 months onwards.
Yeah, yeah.
Wow.
Doctor,
All
even
right.
I've
Okay.
seen for 1 week of NSAIDs also, PPAs is
Yeah.
being used quite
Yeah.
extensively.
Again,
Yeah.
like I said, if there is a previous GI bleed or at high risk, then yes. Routinely, no.
Yeah, thank you. Thank you so much. So I think we've received almost 19 questions. That itself shows how successful was our webinar and the topic what we have selected, Dr. Shamsher. Thank you so much for the valuable, the valuable clinical insights and practical perspectives which you have shared with all of us today. And on behalf of VAMDIS Health Science and the team, I would like to thank all the participants, all the attendees today for taking time to attend our webinar. Thank you so much. You can see, a QR code here. You can just scan and get the CME points from here. Thank you so much. Thank you so much, and good night.
Thank you, everyone. Thank you.
Thank,
Excellent.
thank
Thank
you,
you,
Dr.
guys. Good night,
Shamsir.
everyone.
Thanks,
Thank
Dr.
you, sir.
Shamsir, for your
Thank you.
lecture. Thanks a lot.
Take care. Good night, guys.
Thank you so
Take
much,
Good
Dr.
night,
Shamsher.
Doctor. Thank you.
care. Bye.
Guys, you can just
Thank you,
let,
Cynthia.
let all the participants get the CME points, and then we will leave. Amdis team, please stay back.
Cynthia, once I disconnect, you will not be able to talk to them. So I
Yeah,
believe
just
if you can
give us
make
1 minute, Nahas. Just I want to talk to them.
okay.
Yeah. Because still, I think people are getting the.
Yes.
Mhm.
You want, I can make for you another link. You can go ahead.
Yeah, please. I want
No,
all of them to be there for
no,
some
you
time.
can go ahead because I need to leave. I have an emergency now to go.
Oh, sorry, sorry.
Not personal, just in work, no worries. Meeting.
Nahas, can we start?
One minute.
Yeah.
Cynthia,
Yeah.
I sent you one link. Just log into it.
Hmm.
All right, on the WhatsApp. Just join the meeting now. I will stop this one.
Okay, so they all can join in that, or they can.
Yes, they can. I'll just forward it.
Okay. I
And I
have to
will make you
forward
the
the
host
link to
there.
them.
Yes.